Happy Doctors Appreciation Day. Hope you all got your flowers. In appreciation of you all, we're going to talk about nystagmus and send you out to work. So a very tough topic that ophthalmologists tend to see a patient and run away, right? They call neuro. So the title of the talk is Nystagmus, or discussing a few other jerks. Okay, what are we going to do today? We're going to go through a sort of a tedious introduction with definitions of nystagmus and reviewing the eye movement systems we have, because the nystagmus is a result of a dysfunction in these eye movement systems. We'll go over the history and examine these patients, try to localize nystagmus, first of all, peripheral versus central, talk about positional a little bit. We're not going to get into nystagmus of early life that I think you do in peds. In terms of the acquired nystagmus, we'll try to talk about which forms have localizing value in the nervous system. And finally, something that is often called nystagmus but isn't, are saccadic oscillations. We don't really have enough time to get into treatments, which we could do at another time. So nystagmus is defined as a rhythmic, repetitive oscillation of the eyes that can be physiologic or pathologic. And physiologic, it's in response to environmental stimuli. If you're on a train and you're moving and your eyes have to reset, you're going to have nystagmus, or if you go up into space, or changes in body position. And then there are pathologic forms of nystagmus that are either central nervous system disease, peripheral vestibular disease, or visual loss. When we talk about nystagmus, we first of all want to talk about symmetry. Is it the same direction in both eyes? Is it disconjugate or disjunctive? Or is it totally opposite, so dissociated? So one eye's converging, the other is converging rather than moving in the same direction. Or is it very asymmetric so that it's monocular? And even though the abnormality is the slow phase, which causes the eyes to drift, the direction of nystagmus is defined by the fast phase. So if there's a fast phase to the right, it's right beating nystagmus. We want to say, is it left beating, right beating, up beating, or down beating if it's a jerk nystagmus? And if it's torsional or rotational, rotary, we want to say, is it rotating clockwise, counterclockwise, or to be more accurate, since you don't know if you're talking about clockwise for the examiner or the patient, you may want to say it's beating towards the patient's right shoulder. So you know that it's going that direction. Finally, it could be a combination of horizontal and vertical. And if that's the case, it picks up a form like circular or oblique or even elliptical. We want to characterize the waveform. So here are some eye movement recordings, but you don't have to do that. You can see it clinically. Is there a slow phase and a fast phase? And that's jerk nystagmus, which is the most common. Or is it pendular, meaning slow in both directions, equal velocity in both directions? Or is it a combination of jerk and pendular, which might be the most common thing you would see in infantile or congenital nystagmus? So what causes nystagmus? The pathophysiology is that it's a defect in a slow eye movement system. And we have a lot of slow eye movement systems, such as vestibular, pursuit, optokinetic, and the neural integrator, which allows the eyes to drift off from where they should be slowly. And then the brain says, hey, the world must have moved because I didn't move it. And the saccade corrects and goes back to the original point, and that's the nystagmus. So we're going to talk about the slow eye movement systems, which include fixation, VOR, optokinetic, neural integrator, smooth pursuit, and vergence. Well, let's ask a basic question. Why do we have eye movements altogether? Any ideas? Yeah, you have an idea, Dr. Wilson?
Your head moves,
So what happens if your head moves?
then your eyes would move with it.
And? So your head moves, your eyes move, and then what happens?
It's difficult to have a steady focus on a target if you're moving.
And what happens then? So it turns out that your visual acuity of, let's say, 2020 or 2015 is only a very small central part of your vision, right? Once you go off 10 degrees, you're 2,400 or so, right? Or 2,200. So when you want to see clearly, you got to keep your fovea exactly on where you're looking. Everything else is blurred. Even though you can see hand movement, you can't see detail. So you've got to focus that fovea at all times. So if you move your head, if your eyes didn't correct by moving back, or if you're on some train that's moving or whatever, you need to focus that foveal area on exactly where you want to see. And to maintain images steady on the retina, we have to have these systems to preserve our visual acuity. Because even tiny movements of images off the retina will cause visual acuity to be degraded. And just even walking or even your heartbeat would throw you off. So we have these slow eye movements, which are there to maintain steady fixation and follow moving objects. And these are the systems that we have to hold the eye steady. Visual fixation, vestibular, optokinetic, and the neural integrator. So visual fixation allows us to keep looking at something and the eyes remain stationary when the head is not moving. So this is the simplest one. And it's from the occipital lobe. We look at something and we keep our focus on it that way. The vestibular system allows images to remain steady with brief head rotations. So we have this vestibulo-ocular reflex. The person wants to look straight ahead at the same object, moves their head, and the eyes go equally and opposite. And this is mediated via the semicircular canals, via the vestibular nuclei in the brainstem, to the ocular motor nuclei. The otolith ocular reflex, which comes from the utricle, responds to head acceleration linearly and lateral head tilt. So we have different parts of the inner ear that sense these movements and correct the eye movements. Let's say the vestibular system is overwhelmed, because it's easily overwhelmed by rapid movements or sustained movements. Then we have the optokinetic system, which responds to sustained head rotation and allows us to follow a visual optokinetic stimulus, which in the clinic we use either this drum or the stripe, and we see nystagmus. But the real correction is the slow component that allows us to have our eyes move when we need to. And it takes over for a diminishing labyrinthine signal. What if we want to keep our eyes in an eccentric position off to the side? We have what's called a neural integrator. It overcomes the viscoelastic forces of the orbit that would tend to bring the eye back to the center. Why is it called an integrator? Well, because the people who described all these eye movement systems are engineers, and they figured that in order to figure out what the steady amount of neural output you need to keep the eyes laterally is an integral, mathematically, of the velocity signal that got you there in the first place. So it's called an integrator. So we have a horizontal neural integrator to keep the eyes to the side horizontally, and that's the medial vestibular nucleus and nucleus prepositus hypoglossi. And then there's the vertical neural integrator, which is further up in the midbrain in the interstitial nucleus of Cajal. And the cerebellum, particularly the flocculus and nodulus, also play a role. So that's to keep things steady off to the side. What if we want to fixate a moving target? The main thing we have is smooth pursuit, which allows us to follow a moving target up to a certain velocity, up to 40 degrees per second. It's ipsilateral control, so it comes from the ipsilateral parietotemporal region, parietotemporal occipital junction, and it goes down to the pons for horizontal movements and allows us to look towards that direction. And it has some input from the frontal eye field and the supplementary eye fields, which are in the frontal lobe. But let's say the object is moving close and far. Then we need to converge our eyes slowly and diverge our eyes. And the pathway here is from the occipital lobe to the midbrain, where we have to use both medial recti to converge, or to the pons in order to diverge and use both lateral recti. So this is a slow eye movement system that is disconjugate. So when we have nystagmus, you look at a patient, there's nystagmus. How do you tell what system is abnormal? Well, clinically, you really don't have to if you know what to look for in terms of your workup. But if you did eye movement recordings, you could tell by the waveform which system may be involved. So, for instance, if you have a linear waveform like this, where the slow eye movement is linearly going up, that's the vestibular system. That's the vestibular type nystagmus. If you have a decreasing velocity as you go on, so that it starts out faster and then slower, like this one, then that's a defect in the neural integrator. If you have an increasing velocity as time goes on, like this one, where the slope goes higher on that wave, that's a pursuit defect. That's a smooth pursuit defect. And that's the most common one you see in congenital or infantile nystagmus. So if you wanted to see this, you could do eye movement recordings. Clinically, unless you're in a clinical trial and you want to see if a medication makes something better, you really don't need to do eye movement recordings to make a diagnosis. So those are the slow eye movement systems, and defects in those cause nystagmus. Then we have our rapid eye movement system called the Saccadic System, which allows us to move our eyes rapidly to focus on something that's eccentric. So you can't make a smooth pursuit movement if you want to look from that screen to the exit sign there, because you don't have anything to follow. You need to follow something to make a pursuit movement. So to look from there to there, you make a saccade, a rapid eye movement. It also serves to reset the eyes when you change position, when you're rotating, and it also resets the eyes during pathologic nystagmus. The fast phase are saccades. So where in the brain are saccades controlled? Well, all these places. Frontal eye fields, supplementary eye fields, the dorsolateral prefrontal cortex, parietal eye fields. In the brainstem, the main center is the superior colliculus. And for horizontal movements, the paramedian pontine reticular formation right near the sixth nerve, and the rostral interstitial medial longitudinal fasciculus for vertical. We have these neurons in the brain called omnipause neurons in the brainstem. And these are the neurons that suppress unwanted saccades. And when these go wrong, we have really saccades going wild, like in Opsoclonus. Okay? So those are the eye movement systems. How about adaptive control? Let's say there's environmental change. Let's say someone has a stroke. Let's say someone has a vestibular neuritis. They've got to recover from it. How do they adapt? Well, the vestibular cerebellum, particularly for pursuit, VOR, and gaze holding, and the dorsal vermis and fastigial nucleus of the cerebellum for saccade and pursuit accuracy. So we have these parts of the brain that are able to overcome defects. So much for the basic pathways, and we'll now go on to some clinical stuff. So, clinical history with patients with nystagmus. First of all, they may have a lot of neurologic symptoms. But is there any history related to the nystagmus itself? Most often it's asymptomatic. But sometimes there's oscillopsia or decreased visual acuity. Now, you want to also take a history of, are they on medications? Because a lot of medications, particularly the sedatives, hypnotics, anticonvulsants, will cause nystagmus. You want to know about lithium. You want to know about, do they use a lot of alcohol or drugs, because that causes nystagmus. You want to know about a family history, because a lot of people with nystagmus have a family history of cerebellar ataxia, and so you make a diagnosis that way. If they have central nystagmus, a brainstem lesion, they may have other neurologic symptoms, like long track signs or symptoms, weakness, numbness, ataxia. Or they may have cranial nerve symptoms. So if they're in the midbrain, they may have a third nerve palsy. If they're in the pons, they may have a sixth nerve palsy. What about a history with peripheral vestibular disease, which primarily is a unilateral labyrinthitis or vestibular neuronitis? So these patients will have more prominent vertigo, nausea. They may have tinnitus, hearing loss, and these patients get vomiting as well, as opposed to the ones that have central nervous system disease. On exam, the goal is to determine if the nystagmus is peripheral or central by looking at the pattern. Is it jerk pendular? Does it change direction? Is there a null point? You could do a head thrust test, which we'll get into when we talk about supranuclear disease next month. And if you find that it's central, you want to try to look at the form of nystagmus and say it localizes here. You want to look for long-standing head turns or head tilts, which might suggest congenital nystagmus. And you want to assess afferent function because often nystagmus is associated with afferent disease. So on exam, you examine them in all positions of gaze. You look in right gaze, left gaze, up gaze, down gaze. You say, is it jerk or pendular? You say, what direction is the jerk nystagmus? Is it a rapid, the frequency, is it rapid or slow? Is the amplitude really high or is it low? Is there a point where if you turn their head, they have the least? Is there a null point? And you want to examine patients for a few minutes because if they have periodic alternating nystagmus, they'll have nystagmus that beats in one direction, slows down, and then switches direction. And if you don't watch it for a few minutes, you won't see that. So what are the patterns of peripheral versus central? And where this really comes in mainly is something where the patient comes into a general ER, not usually the Wills ER, like the Jeff ER, and says, I have some vertigo, and you're looking at their nystagmus, you want to say, do they have a stroke, or do they have a peripheral labyrinthitis? And I'm not sure how often you folks get called for that question. In neurology, it's extremely common. So if it's a peripheral unilateral vestibular problem, they will have either horizontal or horizontal plus torsional nystagmus. It will not be vertical. It won't beat up in up gaze or down in down gaze. It does not reverse direction. So if it beats right in right gaze, it will beat right in primary, and then you go to left gaze, it's either gone or will still beat a little bit to the right. It will not change direction and beat to the left if it's a unilateral peripheral labyrinthitis. It's always a jerk nystagmus. It's never pendular. On the other hand, the central nystagmus, the horizontal direction changes with gaze. So right beating in right gaze, left beating in left gaze. It's often a vertical component, so up beating and up gaze, per se. It may be pure torsional. So if there's no horizontal or vertical component, just rotation, that's always central. It could be jerk or pendular, but on occasion, a central disease can mimic a peripheral pattern. And that's for one of two reasons. If you get the vestibular nuclei by themselves, it can mimic it, or there happens to be an artery off the basilar circulation that supplies the labyrinth of the inner ear. And so occasionally you could have a central vascular problem that presents with a peripheral vestibular problem. So you can't just be absolutely sure. So if you have an 85-year-old who comes in with what looks like peripheral vertigo with no central findings, but she's 85 and she's got atrial fib and hypertension and diabetes, don't just assume it's peripheral. Take the whole picture. You want to look for associated findings. Are there head oscillations or are there head turns, right? Because some of the congenital or spasmus nutans have head oscillations, some have head turns. Now, when you come in with an acute peripheral vestibular vertigo, and this is a common situation in the emergency room, patient's got dizziness, they're nauseated, the doctor looks at the eyes, and there's no nystagmus. And the reason is because having your eyes open and fixating dampens vestibular nystagmus. And the time you see it most is when you're not fixating and it's not light and your eyes are closed. So one trick you could do is you can have a dark room, you have them fixate in the distance, you look with a direct ophthalmoscope, and you cover the other eye, as seen here. So they can't fixate, and they can't see because you're blocking both eyes. And you look at the optic disc, and you'll see the optic disc shaking. So you know they have nystagmus. And it's the opposite way of what it looks like because it's the back of the eye, right? So even though it's a direct ophthalmoscope and things aren't inverted, if it beats to the right, the optic disc beats to the right, it's a left beating nystagmus because it's the back of the globe. The other thing you could do is put on these Frenzel goggles that you see here. And these are very high plus lenses. And these goggles often have a light in there so you could see in, but they can't fixate. So you could see a magnified view of their eyes. They can't fixate, and you'll bring out vestibular nystagmus. So these are two ways to see the nystagmus that you don't see otherwise. The other way is actually eye movement recordings, where you can control the lighting, etc. Now, what if they give you a history of positional vertigo? So positional vertigo is vertigo only when I turn one direction, when I bend over. Then you'll do the Dix-Hallpike maneuver. It turns out when people come to the ER with vertigo, they seem to all get the Dix-Hallpike maneuver. But if someone comes in with vertigo that's there for 10 hours, it's not related to a certain position, it's really a waste of time to do this maneuver. And in particular, if you see nystagmus on exam, you don't have to do this to elicit it. This is only relevant when someone tells you I have vertigo when I go in a certain position. So what are examples of peripheral vestibular lesions? Labyrinthitis or vestibular neuronitis, a unilateral viral issue, Meniere's disease, or ischemia in the internal auditory artery. So we're looking for a horizontal, rotary or pure horizontal, which is unidirectional and does not reverse. It's worse when looking towards the fast phase, which is called Alexander's law. And the fast phase is away from a destructive lesion, and they tend to fall towards the side of the lesion. So how does this work? We have, let's say we have damage to, so we normally have two ears, right? And they give equal input into the vestibular nerves, and both of these nerves fire equally. But let's say this is damaged, okay? This is the left ear, it's damaged, it's not firing, the other ear is firing correctly. That means the eyes will tend to slowly move towards the left, because this is pushing them to the left, and the brain says, hey, what happened? And creates these saccades towards the right. So there's a right-beating nystagmus, away from the damaged. And that's how it works with peripheral vestibular lesions. So here's a 40-year-old man with sudden onset vertigo and nausea, and you'll see with the Frenzel goggles some nystagmus. You see a left-beating nystagmus, right? Beats left in left gaze. When they look in right gaze, no nystagmus, right? Left gaze, nystagmus. So it's a unilateral horizontal nystagmus. If you take off the goggles, it'll go away because it's suppressed by fixation. No nystagmus anymore, right? Anybody recognize that guy? What about benign positional vertigo? It's brief vertigo, less than 30 seconds, induced by change in head position. So rolling over in bed will often induce it, bending down and looking up, head trauma, viral infection, or idiopathic. Most commonly seen really after trauma. So the pathogenesis is either canalolithiasis or cupulolithiasis, which is a loosening of these stones sitting in the posterior semicircular canal, and they stimulate the hair cells and cause nystagmus. So, if you have a Dix-Hallpike maneuver, you do this maneuver with benign positional vertigo. If it's in the right ear, you will get a combination of a counterclockwise in one eye and a counterclockwise and upbeat in the other eye. And most positional vertigo is peripheral, inner ear. But there are rare occasions where there's a central positional vertigo. So you have to know these rules that distinguish the two. If it's peripheral, there's a latency. It doesn't happen immediately. It may happen after 1 second, though. So you got to look very carefully. But with central, there's no latency. It's just immediate. When you get down to the head-hanging position, it's there. The duration with peripheral is usually just seconds, never more than a minute. With central, it persists. Fatigability. We're not talking about how you feel, but if you keep doing it, you do it again, it dampens with peripheral. Second, third time, it's gone. With central, it just persists as long as you do it. And then if you go back to the upright position, if it's peripheral, it'll reverse direction of the nystagmus. With central, there's no reversal. It stays the same. So here's a case, courtesy of Dr. David Z. In Baltimore, an expert in eye movements. And this is benign positional vertigo. You're going to see the Dix-Hallpike maneuver, and then the eyes shaking. Go back down with head hanging down to the right. And then you look through the goggle and you see this prominent vertical and rotary nystagmus. And it just lasts seconds and then it goes away. And that's your classic benign positional vertigo. It is suppressed by fixation, so sometimes you don't see it well without the goggles, but you usually do see it. What's the importance of diagnosing benign positional vertigo? Well, number one, it's benign. Number two, there's a treatment. And the treatment is the canal repositioning maneuver, or the modified Epley maneuver. And what you do is you put them through these positions. We won't go through it in detail, but you start with the Dix-Hallpike maneuver, and then by turning the head 180 degrees and then even further down and then sitting them up, what you've essentially done is move those loose stones from the posterior semicircular canal, out of the canal, into the vestibule where they can't cause the problem anymore. And so you can take a situation where people are miserable for weeks or months or years and cure them with this simple maneuver. So very important to know. It's very important to know wherever you practice somebody who does this. It's often a vestibular physical therapist. It could be ENT, it could be neuro-ops, it could be neurology. Someone who does this so that you can refer patients with positional vertigo to get cured. Now we're going to move into more central forms of nystagmus. And the first thing we're going to talk about...
Quick question. So you do get vertical nystagmus then?
Right. So this is the one exception where peripheral disease will give you a vertical nystagmus. So yes, spontaneous, when you see nystagmus without the Dix-Hallpike maneuver, if it's vertical, it's central. But with the positional vertigo, it is vertical and rotary. That's an exception, yes. So we're going to talk first about gaze-evoked nystagmus. Looking in right gaze, this is courtesy of Matt Thurtell, a neuro-ophthalmologist in Iowa. You see you beat to the left and left gaze, right and right gaze, common situation. What's the most common cause of this? It's probably medication, right? I mean, you see people on all kinds of medications that will have a little gaze-evoked nystagmus. But if it's not very prominent, it could be physiologic also. So physiologic nystagmus is unsustained. It doesn't persist. It's at the end gaze, and it's low in amplitude. It's symmetric, and if you keep them at lateral gaze for 30 seconds, it goes away. And if you move them back to three-quarters gaze, let's say you're not all the way out, it goes away. So if you have a symmetric nystagmus in an asymptomatic patient, and it goes away as you move a little bit less to the periphery, that's probably physiologic. You don't have to worry about that. Pathologic gaze-evoked nystagmus is from medications of various sorts, alcohol, or structural lesions in the brain. So we're going to talk about central nystagmus, and we're going to talk about first the jerk varieties and then the pendular varieties, and try to say which kinds localize to where in the brain. So here are the localizing types of jerk nystagmus, and we'll go through all of them. So here's a 35-year-old man with progressive hearing loss in the left ear as well as dizziness, okay? And a lot of these clips are actually from a website that you should all know called the Novel website, which is the Neuro-Ophthalmology Virtual Education Library. There are many videos, many slides on all neuro-ophthalmologic topics. It's free of charge. It's novel.utah.edu because it comes from the University of Utah. And it has collections of all these people in neuro-ophthalmology who've contributed them, as well as most of the Walsh and Hoyt textbook on there, which is the real Bible of neuro-ophthalmology. So it's free for everybody, and you could download things and use them in lectures too. So here's a patient who has vertigo, and he's found to have this large CP angle tumor, and it started on the 8th nerve, and then it compressed the brainstem. So he's going to have a combination of a peripheral vestibular nystagmus from the 8th nerve, as well as compression of the neural integrator. He's going to have a contralateral nystagmus because of that, and because he's pressing on his brainstem, he's going to have an ipsilateral nystagmus. But the features in each direction are going to be different because they're different etiologies. And he's going to have what's called Brunn's nystagmus, which is seen in large CPA tumors. There's a contralateral high-frequency low amplitude nystagmus, that's vestibular, when looking away from the lesion, and an ipsilateral low frequency, high amplitude nystagmus because of compression of the neural integrator. The main point is it looks different in right and left gaze. So this is from the novel website. This is Dan Jacobson. So the other direction, you see a higher amplitude, low frequency. In right gaze, you saw a low amplitude, high frequency. You can just see how asymmetric it is. You see that, you think about a CP angle tumor. There's another localizing nystagmus called rebound nystagmus, seen with cerebellar system disease. So initially, there's no nystagmus in primary position. But you go to the lateral gaze and you get a gaze evoked in that direction. But now when you come back from there, you come to the center and you have what's called a rebound nystagmus. It beats the other direction. So even though you started out with none in primary, once you've gone laterally, you come back, it goes the other direction. And this is seen with cerebellar disease. So here's another one from the novel website. There was no nystagmus in primary to start with. But after going to right gaze, coming back, there's a left beating nystagmus. And you'll see after going to left gaze, coming back, it'll become a right beating nystagmus. It slows down, come back to the center, it'll go the other way. So wherever you came from, it goes the other direction. It's called rebound nystagmus. It's a sign of cerebellar disease. You know there's a cerebellar problem. Dissociated nystagmus is where it's asymmetric. The classic one is an INO. There's nystagmus in the abducting eye, which may reflect adaptation to the weakness in the contralateral medial rectus. So here's a case again from novel, a case of Shirley Ray's with a brainstem tumor with a bilateral INO, and you see the nystagmus asymmetric. Just right beating in the right eye, not in the left. And then look in the left gaze, just abducting, very asymmetric. So this is a classic dissociated nystagmus. Periodic alternating nystagmus is a jerk nystagmus in primary position that changes direction every 90 seconds. So it beats to the right, slows down, stops, beats to the left. In lateral gaze, it's always going gaze evoked. But in the center, it keeps changing direction. And it's because there's a shifting null point on each side of the center with a periodic brainstem-mediated periodicity. And this tells you there's a lesion either at the cervical medullary junction or in the cerebellum, often with cerebellar degenerations. So here's a patient who's turning her head most of the day because if she turns her head, she stays in her null point. But if you keep her in primary position, she's got right beating nystagmus to begin with. It'll then slow down. Occasionally, when it slows down and stops, you get a couple of downbeats. That's quite typical. And then you'll see it start beating to the left. You can tell if you don't watch these people for a long time, you're going to totally miss this. Now it's beating left. So it's periodic alternating nystagmus. Rarely it's congenital, most often acquired, CM, cervical medullary junction, cerebellar disease, in this case, Arnold-Chiari malformation. Downbeat nystagmus beats down in primary position. It's worse in lateral gaze. It is sometimes worse in down gaze, but typically worse in lateral gaze. Same localization as PAN. Cervical medullary junction or vestibular cerebellum. Occasionally toxicity. Lithium is classic, but a lot of the anticonvulsants. Sometimes deficiencies of vitamins like thiamine and B12. sometimes paraneoplastic, and one of the paraneoplastic ones, or even not paraneoplastic, that's been recently described is the antibody to GAD65, glutamic acid decarboxylase. We have 2 cases with that antibody, actually. So here's a case of downbeat nystagmus in a patient who has an autonomic malformation. It's quite subtle in primary position. You hardly see anything. But when you have a look to the side, we will see that it beats down. Down in the right. %40 of these are idiopathic, and we don't find the cause. Often we find a spinocerebellar degeneration that's familial. And there's Chiari malformation right here. What about upbeat nystagmus? It's less localizing than downbeat. If it's worse than down gaze, it's likely in the medulla, but otherwise it could be the junction of the pons and medulla, junction of midbrain and medulla, or cerebellum also. So a lot of different causes, not as well localizing. But here's a patient coming up who had a trauma with a medullary infarct, or actually hemorrhage, and he has an upbeat nystagmus from his trauma. What about pure torsional nystagmus? Pure torsional nystagmus is usually a lesion in the medulla. And when we talk about supranuclear defects next month, we'll talk about skew deviation. And it's often seen with a specific type of skew deviation called the ocular tilt reaction. So this is purely torsional. There's no horizontal or vertical component. So those are the forms of jerk nystagmus. Now we'll talk about pendular nystagmus. And we have all these to talk about. It could be any direction, horizontal, vertical, oblique, circular, or elliptical, if it's a combination. It's often dissociated. The most common cause of acquired pendular nystagmus is multiple sclerosis because of multiple lesions in the posterior fossa. But you can see it in visual loss in kids, toxicity rarely like toluene, stroke, and cerebellar degeneration. So here's a 25-year-old man, has a hypercoagulable state, and he presents with a brainstem infarct. And 10 months later, during rehab, he starts developing oscillopsia. And they send him back because they see a new onset of nystagmus, and they say he must have had a new stroke. And what you see here is an asymmetric, dissociated, horizontal and vertical pendular nystagmus, right? So there's no jerk to this. It's all slow, and it's asymmetric, right? So he's got a pendular nystagmus 10 months after a stroke. Any ideas? What caused it? Is it a new stroke? Maybe, maybe not, huh? What he has is oculopalatal myoclonus, or oculopalatal tremor, which is a rhythmic 1 to 3 per second movement of the palate, eye, face, and larynx, occurring about 10 months on average after a brainstem infarct, usually involving the central tegmental tract or any of the components of what's called Moll-Ray's triangle. Pathologically, it's a hypertrophy of the inferior olive in the medulla, and this is one of the movement disorders that persists in sleep. So if you want to make this diagnosis, you ask him to open his mouth, and you see the palate goes at the same rate as the eyes. So pendular nystagmus in someone who's had a brainstem lesion could be oculopalatal myoclonus. You see pathologically there's hypertrophy of the inferior olive. On an MRI, you might see a lesion like this or more subtle. And often, by mistake, this is called a new infarct. But it's not. It's a degeneration that occurs after an infarct further up in the pathway. A rare thing that's important to know, though, is called OMM, or oculomasticatory myarrhythmia. It's a rhythmic 1 per second pendular convergence and divergence. Eyes go in, eyes go out. It's pathognomonic of CNS Whipple's disease. And these patients always also have a gaze paresis that's supranuclear. You won't see that here, but in this case of John Selhorst, as narrated by Shirley Ray on Novel, this person has Whipple's disease of the CNS and has this classic convergence, divergence, 1 per second. Pretty freaky, huh? So, convergence, divergence. Oculomasticatory myarrhythmia. Why is it called masticatory? Because the jaw is also moving. I think you see it down there simultaneously, the jaw as well. Seesaw nystagmus is one that's very symptomatic. There's elevation and torsion of one eye, depression and extorsion of the other eye, like a seesaw. If it's congenital, it may go the opposite direction. It's usually a lesion at the chiasm, sometimes congenital achiasmia, a lack of development of the chiasm. Can be seen in RP, but also seen in like pituitary adenomas or other mass lesions that disrupt the chiasm. If it's pendular, it's in the chiasm. If it's jerk, it could be in the midbrain. So here's a 33-year-old man who was hospitalized in Philly for a transsphenoidal hypophysectomy, seen one day afterwards. He had a history of diplopia and oscillopsia, and you can see he's post-op. You see the nose packing, but you see seesaw nystagmus. One eye up, one eye down. So often associated with a bitemporal hemianopsia, but if it's in the midbrain, the vision is normal. So those are forms of pendular nystagmus with localizing value. Now we'll talk a little bit about saccadic intrusions or oscillations. So we have systems that suppress saccads, these omnipause neurons, and if they're not suppressed, they are abnormal. So first of all, you could just have a little saccade that intrudes on fixation, so-called square wave jerks. So you're trying to look at someone's fundus, and they don't look like they're fixating because they keep looking off. You tell the lady, look at the light. She says, I am. You tell her she's not. It's not her fault. She's got square wave jerks, right? They're normal, but for some people, they have many frequent ones. And for some, they're very prominent. And so why is it called a square wave? Because if you plotted it, it's a saccade away from fixation, then it sits there, and then it comes back. So if you plotted it, it might look like a square. Now, if it's large, it's called a macro square wave jerk. If it's going constantly back and forth, it's called macrosaccadic oscillations and goes both sides of fixation. But let's say it keeps going and doesn't get any interval between it, like down here. So it doesn't rest in lateral gaze. Then it's actually a flutter, right? If it's horizontal, it's a flutter. It's called ocular flutter. And if it's vertical and horizontal and oblique, it's called opsoclonus. So this lack of suppression of saccades of varying degrees. Square wave jerks are commonly seen in a lot of diseases, but even in normal people to some degree. Saccadic oscillations, these lack of suppression with no interval, are seen with severe disease. So ocular flutter or opsoclonus is also called saccadomania, are multidirectional back-to-back saccades with no interval in between. If it's only horizontal, it's flutter. If it's multidirectional, it's opsoclonus, and it's a defect in suppression of saccades by the omnipause neurons. So what do you have to think about when you see these? Number one, paraneoplastic. Lung cancer in adults, neuroblastoma in kids. It's also seen in hyperosmolar coma from diabetes. It's also drug-induced, but the most common cause is really after a viral encephalitis. Okay? So this is the whole list, but most commonly encephalitis or paraneoplastic. So here's a 25-year-old woman with diabetes and hyperosmolar coma, and we saw her in the ICU, and every so often her eyes would just flutter back and forth. So these are rapid saccades without any interval, little bursts of flutter. So it's no different than nystagmus. It's not rhythmic. There's no slow component. It's just a flutter of saccades. And this lady improved when she came out of her hyperosmolar coma. Here's a 2-year-old girl, presents with imbalanced muscle jerks, and her eyes are wild. And so you take a look at her, and she's got And you can look at her eyelids also going wild. She has saccades, rapid eye movements in all directions, not rhythmic. You can't it's not like a beat of a drum or anything. It's just lack of suppression of saccades going in all directions. This is opsoclonus. Okay? She has a neuroblastoma. She gets treated, and about a year later, you'll see her improved. Much better there, right? Okay. The final type of eye movement we'll talk about is superior oblique myokymia. So this is a monocular cyclovertical oscillation, one eye, not rhythmic. Patients present with oscillopsia or diplopia, intermittent, and it's really idiopathic. But very rarely there have been midbrain tumors described. And sometimes the patient comes in with a history like this and you can't elicit it. What you do is under the slit lamp, you try to look for it, and you try to have them look down in the direction of the superior oblique, and you'll see this little oscillation. And it's like a tremor, really. It's not a rhythmic thing. So here you'll see a couple of beats that look rhythmic, and then it stops, and then starts again. It's almost like this tugging on the superior oblique. So it's unilateral, and it's, in the vast majority of people, benign and responds well to various medications. So to summarize the localizing types of nystagmus, periodic alternating cervical medullary junction or cerebellar, downbeat cervical medullary junction or cerebellar. We didn't talk about convergence retraction nystagmus, which is not a real nystagmus. We'll talk about that when we do supranuclear disease, but that's dorsal midbrain. Rebound is cerebellum. Oculopalatal myoclonus is the olivodentatorubral molar raised triangle. Seesaw is in the chiasm paracellar or midbrain. Bruns is the CP angle. And ocular flutter or opsoclonus is lack of suppression by the omnipause neurons. So that's all I got for you. I thank you. And glad to take any questions. Okay. Come back in 10 minutes for the quiz.